Welcome to Quick Medical Review. Today, I'll discuss infective endocarditis, a potentially life-threatening infection of the inner lining of the heart and its valves recognized among the major infectious cardiovascular disorders. The endocardium is normally a smooth, resistant layer, but when valves are damaged by turbulent flow or degenerative disease, circulating bacteria can attach and form vegetations. This infection most commonly affects the mitral and aortic valves, but intravenous drug use often leads to tricuspid involvement. Transient bacteremia, whether from dental procedures, skin infections, or intravenous lines, seeds the damaged endocardium. Platelets and fibrin deposit, creating a sterile nidus. Bacteria, particularly Staphylococcus aureus in acute cases and viridans streptococci in subacute disease, colonize these vegetations. Other organisms include enterococci, coagulase negative staphylococci, and Hayseck organisms. Vegetations enlarge, destroy valve tissue, and can break off to cause emboli in systemic or pulmonary circulation. Circulating immune complexes may deposit in the kidneys, leading to glomerulonephritis. Let's briefly consider the anatomy and why certain valves are affected. The mitral and aortic valves, under high pressure, are most vulnerable. In intravenous drug users, the tricuspid valve often bears the brunt because pathogens enter through venous circulation. Once colonized, vegetations cause regurgitation, and emboli can travel to the brain, spleen, or kidneys. This explains why endocarditis can present with stroke symptoms, flank pain, or hematuria. Speaking of hematuria, when immune complexes deposit in the kidneys, they cause glomerulonephritis, an inflammatory process that damages the kidney's filtering units. How do you recognize these patients? Besides fever and a changing murmur, look for peripheral stigmata. Janeway lesions are painless red spots on the palms or soles. Osler nodes are tender raised lesions on the fingers or toes. Splinter hemorrhages under the nails and Roth spots on the retina are other clues. Intravenous drug users may have cough and pleuritic chest pain from septic pulmonary emboli. But remember, these classic findings aren't always present, so a high index of suspicion is crucial. Diagnosing infective endocarditis hinges on the modified Duke criteria. Before starting antibiotics, draw at least 3 separate sets of blood cultures to identify the organism. A transesophageal echocardiogram is more sensitive than a transthoracic study for detecting vegetations or abscesses. Laboratory tests often show anemia, elevated ESSER or CRP, and hematuria. When you see Hayseck organisms listed in culture results, remember these are a group of fastidious gram-negative bacteria Haemophilus, Aggregatibacter, Cardiobacterium, Eikenella, and Kingella that can cause culture-negative endocarditis. Management starts with empiric intravenous antibiotics after blood cultures are drawn. A typical regimen for native valve disease combines vancomycin with ceftriaxone to cover methicillin-resistant staphylococci and streptococci. Once sensitivities return, tailor the therapy. Nafcillin or oxacillin for methicillin-sensitive S. aureus, penicillin or ceftriaxone for viridans streptococci, ampicillin plus gentamicin for enterococci. Treatment usually lasts 4 to 6 weeks. Surgical intervention becomes necessary if there is heart failure due to valvular destruction, persistent bacteremia despite appropriate therapy, large vegetations with recurrent emboli, fungal infection, or prosthetic valve involvement. Never underestimate the importance of prophylaxis. High-risk patients, such as those with previous endocarditis or prosthetic valves, should receive amoxicillin before certain dental or invasive procedures. Let's recap the key points. Infective endocarditis occurs when damaged endocardial surfaces are colonized by bacteria or fungi. It often targets the mitral or aortic valve, whereas intravenous drug use predisposes to tricuspid involvement. Classic signs include fever, a new murmur, and peripheral stigmata like Janeway lesions and Osler nodes. Diagnosis requires blood cultures and echocardiography, and treatment involves prolonged intravenous antibiotics with early surgical consultation for complications. Watch out for important red flags such as unexplained fever in a patient with a heart murmur or recent invasive procedure. Prompt recognition and intervention save lives. If you've learned one thing today, remember that a simple question, could this be endocarditis, can set you on the path to timely diagnosis and treatment. Thank you for joining me on this episode of Quick Medical Review. I hope this discussion helps you recognize infective endocarditis when you see it and gives you confidence in managing it. If you found this helpful, share it with colleagues or students who might benefit. Stay tuned for our next episode as we continue to simplify complex medical topics, and feel free to suggest conditions you'd like to hear about. Until next time, keep asking questions and keep learning.